Hello, everyone, and welcome to our INOTA webinar series on TDM of biological drugs in immune-mediated inflammatory diseases. So I think I see a lot of familiar faces. So I think over the last few months, we talked a lot about inflammatory diseases, therapeutic antibodies, TDM, patient preferences. And in this INOTA webinar series, we will talk about a completely different topic. We will talk about pharmacometrics and model-informed precision dosing. And to cover these two topics, we invited two excellent speakers who, by the way, are also INOTA members. I will introduce the first speaker. After that, we will go to the second speaker. And then in the end, we hope to have a very interactive discussion with you all. So if you have questions, feel free to write them in the chat or just to keep them until the end. So our first speaker is Dr. Vincent Aranzana-Climent, who is a teaching and research assistant at the University of Poitiers in France, where he is part of the pharmacology of antimicrobial agents and resistance research team, which is led by Professor Marchand. And during his doctoral studies in Poitiers, Vincent studied PK/PD evaluation and modeling of antimicrobial combinations. Also, Vincent spent some time in Leiden in the Netherlands and in Uppsala in Sweden for 2 years as a postdoc. And now he is back in Poitiers, where he continues to do groundbreaking work on PK/PD and modeling of antimicrobials. And today, Vincent will share with you insights on pharmacometrics. So Vincent, feel free to share your screen and to start your presentation.
Thank you very much, Erwin. Can you see my screen?
Yes, I do.
Okay. So thank you very much for having me for this webinar series. So as Erwin presented me, I'm Vincent Aranzana-Climent. I work in pharmacometrics, mostly focusing on the antimicrobial agents and antibioresistance. But today I'm going to speak to you about pharmacometrics in general. And I made the effort to not speak only about antibiotics. So first of all, what is pharmacometrics? So when we try to understand what a word means, I usually go to a book. And here we have a book called Pharmacometrics. So it's very convenient. And in this book, we define pharmacometrics as a science where we develop and apply mathematical and statistical methods to characterize, understand, and predict a drug's pharmacokinetic and pharmacodynamic behavior, quantify uncertainty of information about that behavior, and rationalize data-driven decision-making in the drug development process and pharmacotherapy. To summarize it, pharmacometrics is the science of quantitative pharmacology. So after reading this definition, one of the first point is that, okay, it will be not only about pharmacokinetics, but also pharmacodynamics. It will be about using mathematics and handling data and making sense of data through mathematics. So the first question that might come to mind after reading this definition is pharmacometrics data science? We hear a lot about data science and machine learning, and this talk will not be about data science because pharmacometrics in the context of data science is using data with mathematical models. And actually, if we take this picture, pharmacometrics is really in the model part of data science. Of course, as pharmacometricians, we will, in our work, we do take the data, transform it, make it usable with computer programs that enable the use of mathematics on our data. But at least in the context of this talk, we'll refer to pharmacometrics as the process of modeling this data and making it speak, if you wish. So the topic of pharmacometrics is very broad, and it is not my intent to provide you with a complete sense of what is pharmacometrics. It would take a lot more than 20 minutes. In today's talk, I will focus on 2 case studies where they used pharmacometrics to answer scientific questions. The first case study will be about pharmacokinetics, and the second will be about pharmacodynamics. So let's get into the first case study. So the first case study is about the pharmacokinetics of ceftazidime-avibactam, which is a combination of antimicrobials. I said I would not do only antimicrobials. I didn't say I would not do any. And so ceftazidime-avibactam is a combination of drugs that is used in the treatment of infections, bacterial infections. And this case study comes from the FDA approval package of a fixed dose combination of ceftazidime-avibactam called Avicaz. So if you ever looked into the database of FDA, they make available to the whole community parts of the data that was submitted to them in view of getting an approval for a drug. And here there was a pharmacokinetic study. And in general, if we have to summarize, the goal of the study was, what is the pharmacokinetic? The goal was to understand the pharmacokinetic behavior of the drug combination in this case. And more specifically, when we ask this question, we ask multiple sub-questions. The first main question is, which dosing regimen leads to which concentrations? The second question is finding, is there any biological variable that we can measure in our patients that would influence the PK? If there is, by how much does this biological variable influences the PK? When your goal is to answer these questions, pharmacometrics, and here pharmacokinetic modeling, is a tool of choice. But in order to do pharmacokinetic modeling, or any kind of modeling of pharmacometrics, you need data. So very quickly, they had a lot of data, that ceftazidime concentration coming from 216 subjects. They had avibactam concentration coming from almost 500 subjects. And for each of these subjects, there are data such as the dosing regimen that they administered, the weight, the creatine clearance, whether they knew whether the patients had any underlying disease. They measured the race of the patients, and a lot more of what we would call covariates. And to represent this data, usually in pharmacokinetics, what you would look at is the concentration of the drug in the plasma in relation with the time after the dose. Here you have, so extracted from the same report, you have a graph summarizing all the concentrations of ceftazidime on the left side, avibactam on the right side, and in relation to the time after the dose. So one thing that is very apparent is that when you have that much data, it would be useful to use mathematics and computers to handle the volume of data in a simple manner rather than doing it by hand. So when we have data, what we do is that we define mathematical expressions of the model or models that we want to test on this data to see whether we can find a mathematical equation or a set of equations that fits the data and that helps us explain or describe at least the data. Here you have a representation of one type of model that we try in pharmacokinetics. This usually the models, so there are sets of differential equations that we can represent with graphical representations such as this one. So here we have summarized the, let's say, the subject body from a pharmacokinetic standpoint into a set of interconnected compartments. So that is called a bicompartmental model, where the drug would get into a central compartment representing the blood circulation, and would distribute into a peripheral compartment, then come back into the central and get eliminated. What is very important, about a pharmacometric model, regardless of pharmacokinetics, pharmacodynamics, is that it is defined by its equations and by unknown quantities that we try to compute. And those quantities are called parameters. So here you have 4 parameters. You have clearance, Q, volume 1, volume 2, and I won't get into detail. What is important about these parameters is that these are the quantities that we compute that help us reason about our data, that help us make our data speak, so to say. And so when we have our data, when we have specified one model that we want to try, there is also one other thing that we have to decide when doing pharmacokinetic modeling, is what we are most interested in relation with our question. What I mean by that is that you could do 2 types of pharmacokinetic modeling. You could decide that you're interested in being able to describe the pharmacokinetics of each patient individually, and that you would call individual modeling, and here I represented with a table. Basically, your goal would be to find the clearance of each patient of the drugs that you tested. Another approach would be to say that what's interesting you is not that much the individual pharmacokinetics of the patients that were enrolled in your studies, but their behavior as a group, their pharmacokinetics property as a group. And this is what we call population modeling, where instead of seeing individuals, individually, we are interested in finding distributions and parameters of these distributions that describe the parameters of our mathematical model for the overall population. And here you have like a log normal distribution with the mean and a standard deviation representing, summarizing the variations of clearance into the study population. Once you have decided on the model and the approach of modeling, then what you do is that you include your data and your mathematical co-equations into software that enable using mathematical algorithms to fit the model to the data. So model fitting, in a general sense, is finding parameters that minimize the distance between the model predictions and the observations. So in this representation on the right side, basically model predictions are the straight line and the observation are the dots. So in a simple sense, model fitting is using a mathematical algorithm to find the parameters that would reduce the distance between the line and the dots. There are many estimation algorithms that exist based on different paradigms. I would not go into detail about that, but know that depending on the type of data and on your question, you will have to use choose the right algorithms. These algorithms are being made available usually through, you have mathematical papers, but then often we implement these algorithms in software to make it more usable and more easily usable. And here I cited a few software that you might know. Then after you have done that, you will have a process that you will apply in any, I think, pharmacometric study, which is quite simple. You prepare your data, you write your model equations into your software of choice. Then you fit the model, which is, so you find parameters. You check whether your model describes your data. And then you do that you can do that for n models, for any number of models. You can try different models. And then compare these models, see whether they fit data or in the same sense, or if like some models fit some part of the data better, and then use these comparisons as ways to get knowledge on your data set. And then I italicize that. Often we select the best model to go forward for using our data and analysis for answering questions and further questions. But I italicized it because it is not a necessary step of the modeling process. There are ways of working with multiple fitted models, such as model averaging, which I will not have time to get into detail, but just know that sometimes you don't end up with one model and it's fine. In this specific case, here you have a small presentation of the final parameters for the self-studied model. I won't go into detail, but when you do modeling, you will end up with parameters that you estimated. And just what I wanted to show in this case is that they use the modeling process to identify covariate effects, which is to identify which biological variables measured in patients would have an effect on which pharmacokinetic parameters. And so, for example, here they showed that the clearance was dependent on creatinine clearance, which makes sense because ceftazidime and avibactam are renally cleared, and creatinine clearance is a measure of renal function. Other covariate effects were found, and this is useful for them because they know that they will probably have to adapt the dosing regimen for different populations of patients. And when you have your model, you have studied your data, what do? Well, usually you extrapolate. And so the good thing with pharmacometric models is that, well, you can use them to do extrapolations because you have a mathematical structure that enables you to answer what-if questions in the sense that, well, now I have a model that tells me if I put that dose to that type of patient, I will have that clearance and thus that concentration time profile. And this is exactly what FDA did. The FDA, when evaluating the pharmacokinetic model and the report, well, the FDA wrote that the originally proposed dosing regimens are predicted to result in substantially lower exposure of ceftazidime and avibactam in patients with renal impairment. So to exemplify that, I pulled the two dosing schemes, and what you can see on the left side is the original dosing scheme, and on the right side you have the FDA proposed dosing scheme. And what the FDA recommended is that they actually increase the dose and or the dosing frequency. And what was interesting is that it was they based their recommendation on the population PK model that was developed by the company. So what they did is that they took the final model and they did simulations of expected concentration with these dosing regimens, and they saw that the concentration were too low to their liking, and then they redid simulation and ended up with these dosing regimen that were recommended based on the pop-PK model. The second case study will be very short because I grossly overestimated underestimated the time I would take with the first case study. But in the second study that I am really enjoin you to read afterwards, they studied something else than PK, because there is not only PK. They studied, so I would say pharmacodynamics, but in this case, it's pharmacodynamics if you consider glucose, injected glucose as a drug, while some would say that it's more QSP, which is quantitative systems pharmacology. But regardless, they tried to model the glucose production and disposal of glucose in patients, the insulin production and disposal, and the effect of insulin on glucose in healthy and diabetic patients. So on the right side, they follow the same process that I explained with pharmacokinetics. So they have data and they have equations and they have a model. And with the data and the model mathematical equations, they estimated parameters that enable them to use mathematics to describe and predict glucose and insulin production and disposal, and the reaction to different dosing regimen of glucose. So there are parameters, and what was very interesting is that then they showed that they can use these parameters to compute glucose sensitivity and insulin sensitivities, which are very important factors to estimate to evaluate the disease progression of diabetes. And with these parameters and these models, they were then able to apply something that we call model-based optimal design to design, to propose a design of experiments where they would minimize the number of sampling times and choose the right dose of glucose to be able to estimate those indices through modeling. And I won't get into detail because I'm already over time, but the point of this study is that they were able to propose a design that would enable good estimation of the disease progression indices while halving the number of samples necessary and minimizing the risk of hypoglycemia during the trial. So in conclusion, pharmacometrics is the science of quantitative pharmacology. It concerns itself with all aspects of pharmacology, not only pharmacokinetics, even though I spent 15 minutes on it. And basically, my take-home message is that if you have a question that can be answered through analysis of pharmacology data, pharmacometrics and pharmacometricians can help you. I would like to thank you very much for listening to this presentation, and would like to thank the INSEM U1017 laboratory for bearing with me for all these years. Thank you very much.
Vincent, thank you very much for a great lecture, and thank you for presenting to us the foundation of the pharmacometrics in a very illustrative way. I would like to also welcome and say hello to everyone, and to introduce our next speaker. It's Dr. Elisabet Nielsen. She's coming from Uppsala University, Sweden. She is also the leader of the working group 2, together with Erwin, of the cost and of the action. But also Elisabet Nielsen is a professor in clinical pharmacy at the Department of Pharmacy, Uppsala University, Sweden. She conducts research in the area of translational and personalized medicine, where mathematical modeling is used as a tool to understand the relationship between the drug dosing, concentration, and the effects. Her research aims to develop and evaluate methods for personalized treatments, where clinically integrated model-based systems may support individualizations based on patient-specific factors. She has a specific interest in antibiotic research and how to advance the understanding of the dynamic interplay between the bug, drug, and the patient, and its implications for optimized antibiotic use. She is the assistant head of department responsible for the research training, and she's currently supervising 10 PhD students. So Elisabet is going to tell us a bit more about how MIPD leverages patient-specific data to optimize drug dosing and to enhance the efficacy and minimize adverse effects. Elisabet, please share your presentation and the floor is yours.
Thank you very much, Katarina. I hope you can see my slides. Can you confirm?
Yes.
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 Very good. And you can hear me as well, I guess.
Yeah.
Good. Thank you very much for that nice introduction. And also thank you, Vincent, for a very nice overview of pharmacometric methods. So in this second part of this webinar, I will go more into the practical use of pharmacometric methods in order to improve the drug treatment in individual patients. So I will discuss model-informed precision dosing and how we can implement this into clinical practice and some challenging and opportunities for this. So what is then model-informed precision dosing, or MIPD in short? So this is a bedside approach. It's a real-time and data-driven individualization method that we use in order to improve the drug therapy in the individual patient. So with model-informed precision dosing, we use modeling and simulation, and we use that in a healthcare setting in order to predict the drug dose for a given patient based on their specific individual characteristics. That is then most likely to improve efficacy and or lower the toxicity in comparison to a traditional dosing. So in this method, we use patient information, so clinical characteristics like body weight and age, for instance. We use information about the dosing history, as well as information from different lab and biomarkers. And this could be, for instance, the creatinine clearance values that informs us about the patient renal function, but it could also be the TDM samples, therapeutic drug monitoring samples. So this information is then used in a model-based context within the Bayesian forecasting software. And this allows us then to predict and understand the individual patient PK/PD so that we can optimize the dosing for this individual. So what is then Bayesian forecasting? Well, as Vincent nicely summarized, the population PK model is a way to store information from previous studies. So it stores information about the typical value of PK parameters like the clearance and volume of distribution, but it also stores information about the expected inter-individual variability in these parameters, and also about the residual error that we would expect, so the residual variability. And based on the population PK model, we can then predict the drug concentration over time a priori, and that is in this figure represented by the gray dotted line. To get a bit closer to the patient, we could also take TDM samples where we observe the drug concentration in the individual patient. However, this information is typically quite sparse, so maybe one sample or two samples per patient. And it's not possible to characterize the full concentration time curve based on only the TDM samples. So therefore, we combine the information that we have stored in the population pharmacokinetic model with the information that we gain from the TDM samples. And to do that, we use Bayesian forecasting. So in the Bayes equation that you can see in the end of the slide, we have information that we gain from the population pharmacokinetic model, so the typical value of the PK parameters, but we also have the information of the expected variability, both the inter-individual variability in the PK parameters, but also the residual variability. In this equation, we also include the observed TDM samples, so the information that we have from the specific patients. And then we minimize this function so that we can estimate the pharmacokinetic parameters in this specific individual. And based on these individual estimates of the PK parameters, we can then predict the a posteriori drug concentration time profile, and that would be then the solid line in this figure. And based on these parameters, we can then optimize the dosing within this individual. So the idea of using model-informed precision dosing to guide the therapy in the individual patient is not something that is new. So this is a very nice publication from 1969 by the late Louis Scheiner, where he describes a computer program that can suggest daily anticoagulant dosing strategies for a specific individual. And what you enter into this program is prothrombin times and the drug dosages, as well as a determined goal and different limits. Within this program, there is also an integrated pharmacokinetic model that is then used to predict the prothrombin times from the drug doses. And then you can predict the future doses based on the predictions that you do within the program. He also describes a small retrospective study where he tests the performance of the program and relate that to different physicians within the hospital, and shows that the doses that was computed by the program were found to be favorable compared to those for the sample physicians. So this idea is not new. However, the clinical implementation has been slow, to say the least. And this is just a snapshot of some rather recent reviews and prospective papers that try to outline why model-informed precision dosing has not yet become a common clinical reality, and some challenges and opportunities when implementing model-informed precision dosing in clinical practice. So what are then the challenges and opportunities when we want to implement model-informed precision dosing in clinical practice? So starting on the opportunities. So today we have access to more data than we have ever had before. So we have seen a shift from paper to electronic healthcare records that increases the accessibility to the data. The patients today are also more well monitored than they have ever been before. So we use TDM quite a lot, and we also have new types of biomarkers to follow the disease progression, but also the efficacy of the treatments that we could potentially include in model-informed precision dosing. We also have access to a lot of different models and softwares today. So for basically all of the drugs that we are using in clinical practice today, we also have population pharmacokinetic models as described by Vincent, but we also have other types of models like the PKPD models, different disease progression models, outcome models, and different AI models that we can use. There has also been quite a good high interest in developing user-friendly software tools that we can use if we want to implement MIPD at bedside, and I will come back to that in the next slide. In general, there is also a higher awareness of the need of precision medicine and the need to individualize treatments today, which open up the possibilities for different collaborations when it comes to finding technical solutions and implementation strategies and funding, for instance. So we have a lot of opportunities today to include model-informed precision dosing in clinical practice. So this is a very nice paper from 2020 comparing different softwares that can be used for Bayesian forecasting. And these software, they differ in the user interface and also the number of models that are included within the software. They also differ in the ownership and therefore they also differ in cost, but also in the type of user support and quality control that they offer. And what's important is also that some of the dosing softwares today are CE marked and registered as medical devices. And they state that they comply with GDPR regulations and that they could be integrated in electronic healthcare record systems. So what about the evidence for improved clinical outcome? Well, there is quite a few papers that show if you include model-informed precision dosing, you could have higher target attainment. And of course, if you believe in your target and you have a higher target attainment, you could also expect a higher clinical outcome. So this is two publications within the antibiotics area for aminoglycosides and vancomycin, where they have shown that introducing model-informed precision dosing could reduce the incidence of toxicity and thereby also decrease the length of hospitalization, and that these methods can be cost-effective. So then over to the challenges, and even though we have technical solutions today, we also have some technical challenges. So even though you have a medical device, there might be local adjustments that are needed. For instance, when it comes to the language and units, for instance, that could need some tweaking. So I previously said that some of the softwares open up to be integrated into the electronic healthcare record systems, but this is also quite challenging. So when it comes to Sweden, for instance, we have a wide variability in different electronic healthcare systems, and it's quite challenging to integrate this procedure within these systems, and they often do different types of updates. Something that is also challenging is that if you want to integrate model-informed precision dosing in clinical practice, it needs a change in typical clinical routines that are used, and this is something that is quite challenging. So it requires novel interprofessional teamwork. So for instance, the nurses, they are responsible for the drug administration and the sampling. We need to have modeling expertise in clinical practice that could interpret the Bayesian forecasting results. And we also need to have the physicians on board, and they need to be dedicated, educated, as well as trained in this methodology. So in order to implement model-informed precision dosing, we need to find collaborations, and we also need to find financial support for this. And in the end, it needs to be endorsed by different professional bodies. So how could we then introduce MIPD in clinical practice? So in order to do that, we have looked at different implementation frameworks that could be used as a support when you want to introduce something new in clinical practice. So we have used parts of the UK Medical Research Council's framework for developing and evaluating complex interventions within healthcare. So what you do is a stepwise process. So first you start by defining your context. You could then draft an intervention that you want to implement. This draft intervention you discuss with stakeholder and get their feedback. And it's also good to identify different key uncertainties that you want to know more about. It's also good to test the feasibility of the intervention components, and then you do this in an iterative process. Within these implementation frameworks, it's also suggested that you do what's called a logic model, where you define the components of your intervention, you define what kind of implementation strategies you will use, and then you link those components and strategies to the outcome that you want to achieve. And those could be related to the implementation per se, the intervention, as well as the clinical outcome. So we have done this within a multi-sectorial innovation platform in Sweden today that consists of a number of partners from academia, healthcare, public authorities, as well as industry. And this platform is called Platinia, and the overall aim is to preserve and enhance the value of existing antibiotics. And within one of the work packages, we implement new methods to promote rational use of antibiotics within healthcare. And there we have introduced the MIPD approach. And we can also use this within the Anotta, which is also a platform for innovation. where we investigate how we can optimize and individualize the treatment for therapeutic antibodies. So one important part of such an intervention when you want to introduce MIPD is to define the work model that you will use. And this will then be an interprofessional work model. So you, for instance, have the physicians that are responsible for the TDM initiation and sampling strategy. You have the nurses that is responsible for the dose and sampling data. And here we have introduced a new role, an MIPD consultant, which is responsible for the Bayesian estimation and the dosing advice. And then we have the physician that is responsible for the final dosing decision. In Sweden, we also have clinical pharmacists that are ward-based and work close to the patients. And the number of clinical pharmacists employed within healthcare has increased quite dramatically during the latest years. So their role and responsibility has been to enter the data into the Bayesian software. They also provide support to the physician when they should initiate the TDM, but also to the nurses, as well as the MIPD consultant, where the clinical pharmacist that works close to the patient can help to interpret the different data that they use. And they can also be a support for the physician in interpreting the dosing decision. And then they could be responsible for the follow-up in the end. So when introducing this, we have started to use it for vancomycin. So for vancomycin, that is a drug that is where TDM is routinely used. Models are available. They have been extensively evaluated and also implemented in different MIPD software tools. Unfortunately, we have seen a gradual decrease in the drug susceptibility, and therefore the doses has slowly increased, and then therefore also the rate of nephrotoxicity. And we also have new recommendations that suggest that we should move from a trough-guided therapy into an AUC-guided therapy, and then we can use the MIPD in order to predict the AUCs. One key uncertainty that was identified was the data quality in the medical records. So we decided to do a sub-study focusing on this. So we did observations where we observed the actual time of dose administration, and then we compared that to the time that was entered into the medical record. And what we could observe was that the great majority of the doses were administered within plus minus 30 minutes of the time that was stated in the medical record. And then we used a modeling framework or a simulation framework in order to evaluate the impact of such errors on the dose decisions. And what we could see was that the MID approach was robust with respect to the plus minus 30 minutes errors, but we could see that we did see some trends for patients with an augmented renal clearance, which would be expected since a situation where we have a rapid elimination would be more sensitive to errors in data quality. So we have now implemented model-informed precision dosing at Uppsala University Hospital since January 2023, and we are now in the process of evaluating both the implementation but also the clinical outcome. So over to the end and some future opportunities for model-informed precision dosing. So what we have focused so far on is to adjust the dosing based on the measured blood concentrations, so the PK monitoring. But we can also expand this to focus on the pharmacodynamics part and use different biological surrogates or endpoint markers of the pharmacological effect. And of course, how to measure the pharmacodynamics or the pharmacological effect depends on the therapeutic area. So within the antibiotics area, what we have looked at so far is to integrate different ways of rapid diagnostics within the antibiotics area. So we have looked at using time-lapse microscopy images where we can follow the growth and killing of the bacteria over time. We use image analysis in order to be able to count and measure the bacteria in these images. And then we use machine learning in order to classify the bacteria according to morphological classes. And then we combine all this information within modeling and simulation in order to link the drug concentration to the pharmacological effect, both when it comes to the count of the bacteria, but also the changes in morphology. And hopefully in the future, we could integrate also not only the drug concentration in the model-informed precision dosing, but also the bacterial susceptibility to the drug. So with that, I would like to thank you all for listening, and I would also like to thank the postdoc and the PhD students that has contributed to this work, and then many collaborators as well. So thank you.
Thank you very much, Elisabet, for great lecture, and thank you for sharing some of your experiences in implementing MIPD at your hospital. So I would like now to call our participants to make comments or ask questions, whether live or in the chat box. We had several comments since the beginning of this webinar. So maybe I can just read the last one by Professor Nick Holford towards you, Elisabet. So can you just make some comments regarding the TDM and MIPD in a practical way? And, as written here, dosing requirements are more than just measurements and Bayesian estimation of the parameters. So perhaps
yes.
Practical aspects.
Yeah, I totally agree. And what we have tried to do is to make this a method that is integrated within the clinical routine. It shouldn't be a service that is provided from the outside. It should be something that is done within the clinical situation, where you can really evaluate different aspects when you work close to the patient. So I think that's an important part, that it's not an academic product or something that comes from outside the hospital. It should be something that is integrated within the daily care of the patients.
Thank you.
Has been an important factor for us when integrating this in clinical practice.
Thank you. Maybe I can just, since I'm here, to ask you a question. When we talk about MIPD, it's based on the model. So how to choose the model or models among so many in order to, perform this optimization and the precision dosing?
Yes, it's a very good question. And I think we have seen quite a few examples of evaluation of model performance in the last years for different drugs. We have also seen examples of like the methodology that has been developed by Sebastian Vischa, where you can use a model averaging approach. So taking the advantage of several models and making an average of these. And I think that's also a good approach for selecting the models. I think it's also, so what's important in the end when you select the model is that if a model has introduced specific covariates, it's important that you have those covariates also included when you do the modeling, of course. I think that estimation. Yeah.
Okay.
So that the selection of covariates is very useful when it comes to evaluating the performance of the model.
I wonder if I could ask the question again about how dosing is done. MIPD has got dosing in the title, but MIPD publications don't, or very rarely give any hint as to how the dose is actually calculated and how the dose is decided upon. So you may be aware of the TDM approach and the TCI approach to dosing. Are you aware of those, Elisabet?
Yes.
Okay. So you didn't mention them, but I think they're at the core of how to decide on dosing. So which method does MIPD use? Does it use TDM or does it use TCI?
So TDM uses, you use the information from the TDM sample, so the drug concentration analysis. And then, of course, you combine it with the information that you have in the pharmacokinetic model that you use. And then you use this Bayesian approach in order to estimate the individual parameters that you have for your individual. And then you use that in order to adapt the dosing. And how to select the dosing, that's something that you discuss in the team. So we have also introduced what we called MIPD rounds, where we discuss the dose selection within, because you will have several options to choose from within this process. So then we have introduced sort of a round situation in the clinical practice where we discuss different dosing alternatives. So I think we will never end up with a software that provides us with one dose suggestion. I think we should have several, and then we can discuss which would be the most appropriate for this specific individual. Would you agree?
Yeah, well, I agree more or less with the final point, but looking into the future, and indeed some things that exist at the moment, for instance, there are closed circuits that can be used to control glucose. So that's an example of using concentration guided dosing to achieve a target. And so I wouldn't rule it out. You said never will happen, but I don't agree with that. It happens for glucose, it can happen for glucose, and it could happen for other drugs. I'm not saying it happens today, but it could happen. So I wouldn't rule that out. But I will just come back to, I think your remarks about TDM are where I find the real problem with the word MIPD. You still think of TDM, or you've said it several times in your slides, and you just said it again. TDM is the measurement of drug concentration. Full stop, period, nothing else. Now, I added the full stop period, nothing else, but you didn't say anything else. MIPD uses measured concentrations, so you could say MIPD uses TDM, that is the measured concentrations, of course, but then it does some Bayesian stuff, and then it goes blank as to exactly how to choose a dose, how to recommend a dose. And I think you don't understand. I asked you if you understood the difference between the TDM approach and the TCI approach. The response suggests you don't actually understand what is meant by that. I'd be happy to send you a paper so you can learn about the differences between them. It's quite important because the TDM approach is certainly less effective than the TCI approach. TCI approach, for instance, has been shown to, with mycophenolate, has been shown to reduce the risk of renal transplant rejection. The TDM approach failed to do that. So I think it's important to understand these terms in order to get the right outcome. If you just stick with the TDM approach, or if you don't know what it is and you're using it, it's basically using a therapeutic window and saying, I'm okay if I'm within the therapeutic window. If that's your approach, that won't work for mycophenolate. So I think you need to pay a bit more attention to the detail of how to implement these procedures in order to get accurate dosing that will achieve the outcome you want.
Yeah, I think it's very good that we define what we mean with the different terms. For the closed loop situation, I think there's a risk that you trust the input data a bit too much. I think it's important that you always evaluate the type of input that you have and that you understand the process, which might be a bit lost if you have a closed loop. I think it's important to be able to evaluate if you have a creatinine clearance value, for instance, you know that is not the truth. It's just an estimation. And you need to be evaluating that in order, based on the patient characteristics. What kind of patient is it that you have in front of you? How much could you trust the creatinine value, for instance? So I think there might be a bit of a risk with the closed loop situation, in my opinion.
Well, I think that's stating the obvious, Elisabet. Can control the glucose. I just use an example, so it is possible to do it. I'm not recommending it with the tools that we have available at the moment. Of course, you have to take into account the risks of making the wrong decision. But in order to be able to use, if you think about the glucose example, you have to pay attention to how would you decide on what the dose would be? How would you, for instance, choose either the dose of insulin or glucose in order to achieve the target that you want? You have to think about those problems and not simply about Bayesian estimation and measuring the concentration. So that's why I'm focusing on, I keep always saying the same thing, ask the same question, how is the dosing done? I think you have to focus on that and less on TDM and less on MIP. It doesn't tell you what the dosing is, I'll just say the MIP. Focus on how the dosing is done, and from that you'll then learn how to do it better.
I agree, and I think that we have found a very good work model that I would suggest for others to use as well, where we really sit down and discuss these things within the team. We discuss them. We have the pharmacists, we have clinical pharmacologists, we have the physicians that are responsible for the patient, where we really discuss the different dosing alternatives, because it is different alternatives and it's not one single alternative that will come out of these methods. And to discuss this in a clinical perspective.
Okay, since we have only several minutes till the end, maybe just to call others if they have some other questions or comments for our lectures. Erwin, what do you say?
No, I think it was really, really interesting, very nice crash courses, and also I learned a lot. It's always nice to see everything together. I was just wondering, Elisabet, you covered a lot of the challenges and also the opportunities. What do you think is like the main challenge? Like, what is the one thing that we really need to deal with in order to bring MIPD into the clinic?
I think it is to find a good working model where you can integrate the full team within this process, and to have it really integrated within the clinical process. I think that's the biggest challenge, where you need to focus and you need to integrate everyone within the team in this.
Yeah, I fully agree. I think so too. I think MIPD is a cross-disciplinary approach, and so many people are involved. It's everything. It's about taking blood samples, measuring concentrations, estimating the PK parameters, the dosing. It's a whole process, and it's complicated. Yeah. And maybe a similar question for you, Vincent. Like, what do you think that pharmacometrics specifically can do to help MIPD play a bigger role in the clinic?
I think that one thing that would be beneficial, at least in the field that I know most, which is antibiotics, would be to have not only PK models but also PD models that we can apply directly with perhaps biomarkers in our patients to individualize the PK and the PD, because indeed what is of a special interest is to reach the pharmacodynamic target, or at least, the real interest is to reach a clinical target that we hope will be linked with a pharmacodynamic target, of course.
Yeah, I think you touched upon a very important point here. We're always talking about PK and concentrations, and we then just hope that we aim for the right target and that it's a good correlation or association with the actual clinical outcome we're interested in. And I think at least for the field of biological drugs, we are ignoring that. We just hope that everything is going to be fine. And I think that's one of the reasons also why some of the MIPD or TDM studies turn out negative, because it's not as simple as that. And we should really also focus on biomarkers and outcomes. Yeah. And I agree, pharmacometricians play an important role there. Okay, great. Are there any other thoughts you want to share? If not, I'm looking at the clock and I see it's 6 o'clock here.
Yeah.
I think
maybe it's a good time also to thank and to mention the Action Chair, Professor Denis, and also Professor Mehmet, who helped us a lot with these webinars, and Professor Yorgos, right? And of course, all the others who were, indirectly involved in this and all the other webinar series. I think this is our last webinar before this summer holidays, right? And our next webinar will be in September, right? So I'm not sure about it will be about regulatory and industry perspective on TDM and MIPD. So we will keep you informed. And Erwin, maybe you would like to say also something for the end.
Also, so thank you, Katrina, for hosting this session together with me, and thank you again, Elisabet and Vincent, for the very nice talks. And yeah, I need to thank you all for participating also in the discussion. And if you are not an INOTA member yet, feel free to go to the website inota.eu and join us. It's a very nice initiative, and we're always looking for more members to improve TDM practices of biological drugs in the future. And indeed, I think not much left for me to say. I wish you all a very nice summer holiday, nice break, and we hope to see you again in September. Thank you all.
Okay. Thank you very much,
Thank you.
and thank you all.
Thank you.